My name is Kinga Budai, and my research field is about antibiotic dosing in critically ill children. I am a clinical hospital pharmacist in the pediatric center, and my supervisor is Csaba Lódi. My scientific methodology supervisor is Budai currently, and my statistician is Szilvia Kisdala. My vision and my mission are to improve the effectiveness of antimicrobial therapy and extend the life expectancy and decrease the risk of developing antibiotic resistance in critically ill children. So my two topics aim to investigate the advantages, the disadvantages of extended infusion of beta-lactams in pediatric patients. Let's start with the first topic. So the underuse of antibiotics is a real problem in medical practice, and it is essential to maintain the plasma concentrations above the minimal inhibitory concentrations throughout the whole dosing interval. And especially critically ill children are exposed to the risk to be underdosed by antibiotics. And concerning the beta-lactams, there are three types of administration. The standard short-term bolus infusion, the extended infusion, and the continuous infusion. And I put together the extended and the continuous infusion. Among adults, it has been proven that the extended infusion has a benefit, and it was associated with a significantly lower mortality rate in a meta-analysis. However, in the case of pediatric patients, we don't know whether the extended infusion has the same effect. So our aim is to evaluate the clinical efficacy and safety of extended infusion of beta-lactams. We use this PICO framework, and our outcomes are clinical outcomes such as the mortality, the therapeutic effectiveness of failure, the length of stay, the adverse events, and so on. A systematic search was conducted in 4 databases, and at first we found 32 eligible articles, but after that only 18 articles were included in our meta-analysis. Our first primary and hardest outcome is the all-cause mortality. A subgroup analysis was conducted among RCTs and non-RCTs, and the population is clinically heterogeneous. It means that the patients had different diseases, comorbidities, they received different antibiotics, and they had different ages. And we used the odds ratio to measure this effect. And if the odds ratio is less than 1, it means that the event is more common in the bolus group. And we can see that the overall odds ratio is 0.74. And it means that in the extended infusion group, there was a significantly lower mortality rate, which has a paramount clinical importance, and it is a groundbreaking result. After that, the infection-related mortality was evaluated. We could include only 4 articles, so the number of cases are very low. But the odds ratio is 0.52, and it means that the extended infusion led to 50% less mortality rate. And it is a very promising data, but of course we need further investigation because of the low number of studies and patients. The microbiological eradication is another objective tool of effectiveness. The population is small but homogeneous because every patient was treated with meropenem. And the odds ratio is 3.18, and it means that with extended infusion we can achieve an early microbiological eradication 3 times more likely. And this result can explain the findings in mortality. Okay, the next one is achieving the pharmacokinetic pharmacodynamic target. In the case of beta-lactam antibiotics, so these are time-dependent antibiotics, and it is recommended to maintain the plasma concentrations above the minimal inhibitory concentration. And we have two plots because in the study of Moimoncal, they measured the medium and the lowest concentrations. And in the case, the extended infusion is also favorable. And at last, we examined the adverse events, the acute kidney injury and the hepatic adverse events. And the odds ratio is nearly 1, and it means that the extended infusion is considered as safe as the short-term infusion. Our strength is the rigorous methodology, and it is a hot topic in a vulnerable population, but we have several limitations, the limited number of trials and cases, the heterogeneous population, according to the comorbidities, ages, and we assessed high risk of bias. As conclusion, the extended infusion is more effective in early microbiologic eradication. It is associated with a significantly lower mortality and it is considered safe. In implication, we can advise the use of it with therapeutic drug monitoring, but further high-quality RCTs are required to confirm this data. Our manuscript was submitted a month ago, and we received comments, recommendations, and now it is under revision in the eClinical medicine. My second project is the same, but it is a clinical trial. So we already know the administration modes of beta-lactams, and it is common knowledge that higher probability of target attainment was observed in several pediatric pharmacokinetic studies with extended infusion. So there are a lot of population pharmacokinetic studies, and our meta-analysis showed the clinical benefits of extended infusion, but with limitations. So we would like to decrease these limitations and conduct a clinical trial. So the PICO framework is almost the same as the previous one, but we would like to focus on the plasma concentrations. This will be our primary outcome. I would like to introduce our protocol briefly. So every pediatric patient with suspected or proven infection admitted in PICU and NICU will be included. So the proven infection based on culture positivity and the suspicion based will be based on the signs of infection. And the meropen, piperacillin, tazobactam, ceftazidime, ceftriaxone can be measured. Here are the exclusion criteria. And of course, we would like to make two groups, two main arms, the extended and the short-term infusion, but we would like to subdivide these groups by age. So there will be a difference between newborns and older children. Our primary outcome based on the plasma concentration, so we would like to calculate the proportion of patients achieving the pharmacokinetic pharmacodynamic target, and our sample size calculation was done based on this outcome. And the secondary outcomes will be clinical outcomes such as the mortality until hospital discharge, the microbiological eradication in different time points, and the clinical response, clinical success rate, and the length of stay. So in summary, my aim is to ameliorate the antibiotic therapy in critically ill children. And I would like to thank you for your attention with a quote: "Anyone whose goal is something higher must expect some days to suffer vertigo."
I'm just wondering whether you have any data on cost effectiveness, and maybe would you like to include it in your clinical trial as well as an outcome?
Thank you for your question. We don't have data about this, and in my opinion, it doesn't differ between the two groups because the duration of the antibiotics and the dose were similar in the extended and the short-term infusion group, we don't plan to investigate this outcome, but we will consider it. Thank you.
Kinga, I saw in your search key prematurity. Have you got any data for preemies in the literature? Because, it's a very huge problem. We got a 20 or 30% ratio in very low birth weight infants.
Yes, we included 4 neonatal articles. And to the best of my recollection, all of the newborns were premature. So, and all of them received meropenem antibiotics in the late onset sepsis, and it seems that it is promising.
You mentioned clinical cure is a result of your first project. What was the outcomes of the analysis?
Yes, I cannot present this outcome because the lack of time, but there is a discrepancy. There is a discrepancy between the mortality and clinical cure, and the clinical cure did not differ significantly, but it is a subjective tool, so hopefully the extended is better.
In your clinical study, you are going to include patients with different kind of beta-lactam treatments. So is there any difference between those effectiveness, side effects? So what do we know about this?
We were able to conduct a subset analysis only in the case of meropenem, and it is better in the case of extended infusion, but I don't know other data about the different antibiotics.